Good morning, everyone, and thank you very much for joining us for the second of our live webinar. Thank you so much. Last time, for our previous webinar, we had well in excess of 500 listeners, and we increased capacity for this one today. So we hope that more of you have been able to take part this time. As usual with our webinars, we will be proceeding quite quickly through a number of complex topics. And what we are doing today, we are trying to look at what is going to happen to our movement as a whole as a consequence of what's happening right now with COVID-19. We will be tackling some complex issues. Political issues, what are the government going to do about dementia now that COVID-19 is preoccupying so many people? What's going to happen to diagnosis, for example, now that people are not seeking diagnosis because they are too worried to attend clinics, or clinics may be closed. And we are going to look at clinical trials for dementia, what's happening with them, as well as having a look at what is going on in the vaccination debate, as we know that many of our audiences are interested in that. I am Paola Barbarino, and I am the Chief Executive of Alzheimer's Disease International. Many of you, of course, know me already by now, but just in case you were wondering. So before I move on, and we are going to go to the next slide now, I would like to remind you that we are currently collecting funds for our emergency appeal. We are a charity, just as many other charities, and we continue to have everything in our preserve free, where everybody can access everything that we do. But nevertheless, we need fund like any other charities. So if you have an opportunity to donate to our emergency fund, or if your company can, please contact us, and you can see how to donate on this slide. Now, as I was saying, we are going to look at 4 different topics. So next slide, please, Annie. And before we do that, we're going to ask all of you who is taking part in this webinar. And this will allow us to gauge the kind of audience we are having. So we will be doing a poll, and we will be asking you now to take part in this poll. Thank you very much. So we can see quite a few health and social care professionals, quite a few volunteers or employees of Alzheimer's and Dementia's Association, quite a few researchers, some family care partners, a few people living with dementia, some government and industry representative, and multilateral organization and grant makers. So thank you very much. I think, quite a lot of actually people from industry today, from health and social care professionals, today. Well, welcome to all of you. It's great to have an idea of the makeup of our audience. So thank you very much for that. I've already talked about our agenda, diagnostics, that's what we start with. The political deprioritization of dementia. We'll attempt a brain gym session with our director for Southeast Asia, Suharya, the impact of COVID-19 on the diagnosis, and some glimpse on the biopharmaceutical industry. Now, our speakers today on the post-diagnostic support and the fact that it's at the moment really not available for families and for carers. We'll have Dr. Lee-Fay and Nigel Hullah. Dr. Lee-Fay is with the University of Sydney, Nigel with the Nations Dementia Working Group, and then Glenn Rees, the chair of Alzheimer Disease International, will bridge those 2 topics and introduce us to the next, where we have Dr. Jón Snædal from the Ministry of Health of Iceland and Dr. Nils Dahl from the Federal Ministry of Health of Germany. Then we will move on to the diagnostic issue. We'll have Professor Ricardo Allegri of the FLENI Institute in Argentina, Professor Philip Scheltens from the Netherlands. And finally, David Jefferies from the IFPMA will lead us through the issues concerning clinical trials and vaccination. So without further ado, we will move to the next slide. Please bear in mind that at the end of this webinar, myself and Ricardo Allegri will actually, myself and Sergio Gauthier of McGill University will lead a discussion about all the various topics. You will be able to ask questions throughout. Please, however, do not raise your hand on Zoom because we will not be able to pick up those questions. If you have a question, please communicate to us through the chat box. Write your question in the chat box and we will try and pick it up. So with team 1 starting, unavailability of post-diagnostic support and social services, may I ask Dr. Lee-Fay from Sydney University to give us a piece. Thank you, Lee-Fay.
Hello, everyone. So I talked to some of the consumer advocates I work with about their needs, I guess, during COVID, because to understand, to get some understanding of the needs and what services not being available, how they might impact on them. Next slide, please. So what would social distancing layered over living with dementia be like? For someone who's been newly diagnosed with dementia, for someone newly diagnosed with dementia, click please. It's dealing with significant personal changes as well as dealing with significant world changes. Click please. So really looking at how you would adjust to diagnosis and your self-identity and relationships with others, which you would hope that post-diagnostic support would help you with when there's so many other changes in the world. We don't really know about that. Click please. And we know that after diagnosis, it's a time for planning, legal, financial, lifestyle planning, and that's going to be disrupted if there aren't post-diagnostic supports. Click. You can just click through those and I can read them, that might be easier, thank you. So we know that we all have less opportunities to maintain our function, our independence, and our physical health. Can you just click through all those? It might be easier, thanks. Thank you. But we also know that people with dementia might find it more challenging to talk by phone or video chat. We all need more support from family and friends, including people with dementia, which leads to increased stress for the care partners. But interestingly, people with dementia are telling me that the stay-at-home routine may actually help them support their cognition and function. But it can also, for some, lead to frustration and boredom. And social distancing may exacerbate social isolation, but some people with dementia are saying, well, I've been socially isolated already, and it makes, minimal difference to me. So keep clicking to the next slide, please. You just click through those, thank you. So in terms of post-diagnostic supports, I think the important point is before COVID, people didn't have lots of post-diagnostic support. What we know here in Australia, and by speaking with our partners in Europe and North America, that in most places, public clinical appointments have been cancelled or are currently being conducted by phone or video chat. So for dementia, this means that cognitive retesting is difficult by telehealth, and you might need a new test if you need your medication titrated up or renewed. For people who are looking for driving assessments, you can't get one now. All groups are cancelled, so social support groups, exercise, cognitive stimulation. Some services we talk to are trying to go online, but this is slow and I think has been challenging, and day programs have been cancelled. Because you have less opportunity to talk to people, there's actually less prompt to help seek. And we know in Australia that people are withdrawing from home care services because they're afraid of getting infected. So if you take this all together, if you click please through the next, thank you. We know that people with dementia are getting less therapeutic, less practical, less emotional and informational support because services aren't available. Click again, thank you. And we can only guess on what consequences there are on the long-term trajectory in terms of the health and function of the person with dementia, as well as how they might use services in the future, as well as the impact on the people who support them. I think I've just under 5 minutes, Paola.
Thank you very much, Lee-Fay. That has been a great presentation. Can I now please call Nigel Hullah, who is a dementia advocate and the chair of the Nations Dementia Working Group, to please go through his presentation. Thank you, Nigel. You may have to unmute yourself.
I've done it. Good morning, everybody. I'm going to, as chair of the Nations Working Group, I played a role in helping to deliver 3 webinars around the impact of COVID-19. In all, we reached out to 350 people, professionals, advocates, carers, and people like me with a diagnosis. The webinar structure and subject are designed and delivered by people with a diagnosis, so the evidence and contributions are what matters to us. And I'm going to actually speak for those 350 people. I'm not going to speak for myself, although I've got my own views on this. There is a fear amongst people living with a diagnosis and their carers that there will be a loss of skills due to social inaction caused by the lockdown requirements. That friendships, contacts, independence and relationships with partners and carers will suffer because there will be an estrangement, in particularly if the lockdown considers some for longer than probably it has done up to now, although all indications are that we may be seeing an easing fairly soon. The stress of caring is well recognized, but is also understood that caring for someone with a dementia brings added pressures, and some of these pressures, including during lockdown, reassure us about the availability of medication and the much needed recognition that those with a diagnosis of dementia were as vulnerable as those with a medical vulnerability. This seemed not to get over to our particular government, who seemed to conflate the two. The daily briefings of the government were found to be too general, and that people needed more specific details about what was happening. There were concerns over carer burnout, because during the lockdown there was no space, and during the fact that services were being curtailed, and face-to-face services in particular, there seemed to be a concern and a recent survey by Carers UK showed that there was an increase of 14% on average time devoted to caring duties due to lockdown. Some people used the drop-in centres and the face-to-face as respite care because it gave them a little form of breathing space, and that wasn't there anymore. And there was a worry as well that perhaps post-lockdown this would not happen. There were concerns, of course, about what would be needed after the social distancing measures were relaxed and changed. It was felt that some repair work was needed to be done, because we don't know what the final casualties are going to be. We know what the medical casualties are going to be, but we have no idea what the fallout is going to be between the relationship between families and carers. We will need re-engagement, resuming at a pace agreed, not led by expediency. When social distancing measures change, people living with dementia felt that they would be more reliant on their carers and would need more support as they adjust back into their routines. And to help this, we will need to rebuild confidence in one another, and the importance of dementia friends and allies group worldwide cannot be underestimated. Ensuring services are reintroduced in a timely manner, not rushed at because suddenly the social distancing measures are lifted. I might say that at this point, say one thing that come to my attention is the depth of character of people affected by dementia. This depth of character allows us to face challenges as they come on day by day basis. And we were united against dementia. We are now united against dementia and COVID-19. And I think that this depth of character may very well be limitless. And we also would like a robust inquiry into the operation around lockdown, particularly of the preparations that were made for us. Thank you, that's all I have to say. And thank you for your time, and thank you for the opportunity to speak.
Nigel, thank you so much. I mean, you've raised some really important issue from the point of the trust between carer and the person with dementia and all the issues relevant to that. But the last point you made about the fact that we will all have to study for years to come what exactly happened in these preparations for lockdown and how a particular category were excluded really from the thinking of what was going to happen to them. Those are going to be important points. And you know, as many listeners do, that we've been also looking at the human rights debate within this whole evolvement of the situation. Now, we're going to take a few questions now. And I've seen that there's been a healthy debate on the chat line already, but I'm going to ask you a question that arrived to us before the start of the webinar. Somebody asked, how do you balance the caregiver wearing a mask if somebody with dementia has COVID against the fact that somebody with advanced dementia may find that frightening? So can I ask first Professor Lee-Fay to tackle the question, and that Nigel, quite briefly, if I may add.
I think that's a really difficult question because it probably depends on what the situation is and how much risk there is. So it would depend on the situation, how you would manage that. I mean, if for infection control reasons, the caregiver had to wear a mask, then you would try and find the friendliest, safe mask you could find. I mean, that would be one strategy. Trying to explain why it's happening, trying to use distraction and other techniques that we use. That might be one way of doing it. I mean, if it's possible to not wear a mask and for other reasons, then that might be the choice that you would make as well.
Thank you very much, Lee-Fay. Can I now ask Nigel to unmute himself and see whether he's got any tips about that question?
Well, it's a very difficult, you know, as the previous speaker said, it's a very difficult thing to come to terms with. It's going to be a very worry if somebody's in hospital with COVID-19 or a carer turns up with PPE stuff on. It's going to be quite distressing anyway. And picking up on the signs and the cues that the person may be exhibiting is down to the skill of the people who are actually at the bedside or in front of them. One can only hope that people will take a reassuring approach. I've not heard any differently yet. The people wearing the mask, the PPE equipment themselves are aware of the impact that might have. So the reassuring voice, so long as there's some form of eye contact, facial, we can pick up on facial cues, and constantly things that are explained to us as they're done. The reasons why people are wearing masks, the reasons why, you know, the situation is quite different. Of course, the other issue is, of course, there's a lack of support from a familiar face, isn't there? And I mean, you can't replace that. It doesn't matter what the mask looks like.
Nigel, thank you so much. Many people on the chat line I can see are also reminding everybody that wearing a picture as well as a mask, a picture of yourself, if you do have to wear protective equipment, may contribute to lower the fears. Now, we have had some other very interesting questions, but unfortunately we won't be able to tackle them at that point. We're going to move on to the next topic, which is the politics around our movement. So we may still pick some of this question in the final conversation with Serge Gauthier. So can I now ask, please, Glenn Rees, the chair of Alzheimer's Disease International, the former CEO of Alzheimer Australia, to unmute himself and bridge us between this topic and the next. Thank you, Glenn.
Thank you, Paola, and hello, everybody. My task in a few minutes is to take you through what I see as some of the politics of where we're at. As we've just heard, COVID-19 has had a devastating impact on people with dementia and their families, and it's emphasized particularly the social aspects that many of us have talked about for many years. But I want to emphasize that the crisis has also given us opportunities, as Harley Rang from China has said several times during these webinars. This is because advocacy is both about empathy and about relevance. Relevance, that is, to governments. The crisis has given us all an opportunity to talk to our governments about the opportunities to do better for people with dementia at this most difficult time. We've been able to tell the stories of people with dementia and carers. We've been able to contribute to guidelines. We've been able to raise ethical issues in relation to access to care and discrimination, and to provide advice. So the crisis has generated new language and an emphasis all of its own. And we have to realize that there is now a different debate which we can take part in. It's a debate that has more emphasis on planning, more emphasis on aging, social isolation, discrimination, quality of care, and elder abuse. These are core issues we've all talked about for years, but now they're in a different context. I think that ADI members and ADI itself is well positioned with the Global Dementia Action Plan and the WHO policy brief on older persons to take advantage of this situation. I would particularly say that the WHO policy brief that was issued recently is one of the best documents I've read on aged care. You will find in it 4 priorities which suggest the ways in which we can build more inclusive, sustainable, and age-friendly societies that are fit for future. If you've not read it, please do. So while we can anticipate as advocates that it will be difficult to find space in scarce health resources for dementia, there will be opportunities for us to be at the government's door when it opens, as surely it will when there is a post-COVID analysis. Within the Global Dementia Action Plan, I believe there will be opportunities to advocate for 4 particular priorities that are central to the quality of life of people with dementia and their carers. These are to argue for increased resources for primary care, to provide access to dementia diagnosis, post-diagnostic support, and medical care. Second, it will be possible to argue for a higher priority for long-term care, which has been a second-class citizen in aged care policy for so many years, and to get a higher priority for community care. Third, it will be possible to argue for strengthened social and legal frameworks to protect human rights, develop social networks, and end of life decision-making. Fourth, it will be possible to argue for measures to improve the quality of residential care, and particularly training for dementia care. There is nothing new in any of those issues. It's just that I think there's the opportunity now to argue them in a different way and perhaps even more powerfully. So it's not too soon to develop priorities and strategy. Thank you very much.
Thank you very much, Glenn. It is certainly true that there's been a lot of work going on, and there will be more work going on in the months to come if we are to seize this moment. Now, you will have seen that in the chat line, we continue to have plenty of Q&A. Some people are also writing replies. There's been quite a few answers to the question around masks, using face shield instead, which is great, but not everybody, especially in lower and middle income countries, have had access to those. So we need solutions that are useful for the whole of the globe. But let's not forget that ADI is a global organization, and that we aim to find solutions for people in all kinds of circumstances. I think we are welcoming today an audience from over 70 countries. So thank you so much. Now we're going to move swiftly to what Glenn was talking about. So the fear we have about the political deprioritization of dementia. And I'm going to hand over to Dr. Jón Snædal from the government of Iceland, which very recently, in fact, it was only a few weeks ago, and with our great joy announced its national strategy for dementia, brand new. So a country that, despite the angst of the last period, has still prioritized dementia. So a positive, important act of love for all the people that are living with dementia in Iceland. Jón, if you would like to share your thoughts with us. You may need to unmute yourself.
Thank you so much, Paola. Good evening, Australia. Good afternoon, Europe. And good morning, Americas. I'm speaking from Iceland. We have a population of only 360,000, and we have had a quite young population with around 13% above the age of 65, but this is changing quite fast now. So I will just share with you what we have been doing for the dementia strategy. Our parliament decided in 2017 to have such a strategy, but due to general elections and forming a new government, it was a little bit delayed. But it started in late 18 and it was ready in mid 19, following consultations with major stakeholders. Among them, of course, individuals with the diagnosis and their relatives as one major stakeholder. Then there was an action plan worked on since last fall. It was then finalized in February, but then the COVID started, but it was a very positive sign that the Minister of Health released this action plan actually in mid-COVID pandemic on 8 April. And I think that is a sign, a positive sign that this will not be deprioritized on behalf of the health authorities. Just a very few points, major points of this dementia strategy, which actually includes 48 measurable action points in 6 domains. We are arguing for to establishing dementia-friendly societies. Of individuals with dementia and the relatives should guide all actions. The role of the quite active Icelandic Alzheimer Association has been stipulated. It was stipulated also that it was a right of patients or individuals to have a timely diagnosis, and then to have quality indicators used in all parts of the service. Coming to the COVID, we have had in our community the test, track and trace. I think, can you change the slides? Yes, so test, track and trace, it was established from the very beginning, and we have had more than 10% of the population tested by end of April. And due to that, we have managed quite well, you could say. We have a death rate of 3 for every 100,000 inhabitants, and actually no excess overall death rate in the country in the first 4 months of this year. But on the negative side, there was a ban on visiting into nursing homes residents quite early, and that was quite a heavy burden for individuals with dementia. It also catches the attention of the media, so it has been discussed openly in society, just this problem. Also, of course, there have been delayed in diagnostic workup because the ambulatory has been closed until just this week. We are just opening very slowly now. So there's a delay in the diagnostic workup, and of course that is a worldwide problem, I would think. There have been restrictions on daycare centers, but generally they were not closed, but they were managed in other ways, so there were smaller groups coming. But many had fear of the virus and stayed home with the families, and we have seen quite many problems associated with that. The financial implications of the pandemic for the dementia strategy is of course not clear at this point because the pandemic is not over. But we at least are quite positive. We are quite happy that it seems as the dementia strategy will not be deprioritized in our country. Thank you.
Thank you very much. Very interesting presentation, and also very timely at this point in time, connecting it with COVID. Now, without any further ado, Dr. Nils Dahl, please, now to present. Thank you.
Hello,
Nils.
everyone.
Yeah.
Can you hear me? Yeah. I will give you a short update on our work on Germany's national strategy on dementia. Next slide, please. Yes, the strategy itself, or the draft of the strategy, was developed in 2019 and 2020, and the final draft is currently being coordinated between all federal ministries and is scheduled to be adopted by the federal cabinet in June. So we had some delay due to the COVID-19 pandemic, but the federal government is not to prioritize the work on the strategy. And as my colleague from Iceland said, I think that's a very good sign. Work on the strategy follows a coalition agreement of the current government to further develop our alliance for people with dementia. So that's previous work that has been done from 2014 to 2018. And in addition to this alliance, also existing measures of all state governments of Germany and of non-governmental actors, and of course dementia strategies of other countries, and international action plans such as the WHO action plan or the WHO guidelines on risk factors considered in this work. Next slide, please. Work on the strategy included quite a number of different actors. Next to government actors of all policy levels and policy areas, the German Alzheimer Society kindly served as a vice chair of the steering group, and then also providers of healthcare and long-term care, as well as professional associations and research institutions, and our healthcare and long-term care insurance funds were involved in the drafting of the strategy as well. Next slide, please. These actors all agreed to join forces to work on 4 priority fields of actions. Number 1 is to build dementia-inclusive communities by strengthening structures that enable persons with dementia to socially participate. Number 2 is improving the support for people with dementia and their family caregivers. Number 3 is improving the quality of care in all care settings, be it in medical care, in LTC facilities, or in outpatient care services. And number 4 is to promote research and innovation to gain more knowledge on how to prevent dementia or how to use new therapies to fight back the disease. Next slide, please. So these 4 priority fields contain 27 goals and 162 so-called concrete measures to substantially improve the everyday life of people with dementia. Examples for such measures are to increase the number of local dementia networks, or to conduct coordinated campaigns on dementia awareness and dementia friendliness. And these measures will be monitored continually until 2026, when the first comprehensive monitoring report will be issued. And this report will also recommend on how to further advance the strategy afterwards. As the strategy was mostly developed before the outbreak of the COVID-19 pandemic, some measures might need to be adapted to the new situation. As you all know, and as a number of previous speakers already said, people with dementia are not only at a higher risk of maybe suffering from COVID-19 related diseases, but they also are particularly affected by restrictions that were being issued in relation to the pandemic. So all involved actors will need to take this into account, and for example, measures that include a participatory approach might to be postponed or changed in a way to keep going and implement this strategy. Next slide, please. In addition to the strategy, some of the COVID-19 related measures that the federal government and the state governments issued already aim at protecting and supporting people in need of care and their families and also the professional caregivers, and can therefore help to stabilize the care arrangements of persons with dementia. Examples are increased testing capacities in various care settings, and to provide possibilities, also financial possibilities for flexible solutions if the usual care arrangements cannot be organized. And all this shows, I think, that the implementation of our national strategy on dementia will remain a priority for the federal government, but that, of course, we might have to change some of the content and adapt some of the measures to the new situation. Thank you.
Thank you very much, Jón and Nils. I have to say that a lot of the questions that we received before the webinar were exactly about two of the points that you raised, which was adaptation. What will the government strategy need to adapt in order to face the current situation? And I think both of you have addressed that. But there's another question that has been coming in, and that is around the issue of day centers. So there's a lot of concern and a lot of hope that day center face-to-face activity may resume at some point. Can I ask Jón first and then Nils to say whether your governments have had any thought about how some level of face-to-face interactivity may be introduced? And Nigel, well, you have also a question for the government. I invite you to unmute yourself and let me know during the conversation.
I'm actually not hearing that.
Okay, so I'm Jón from Iceland. So we have had a group that has been monitoring the nursing homes and daycare centers on almost a daily basis for the last weeks, and to implement various tasks and strategies for the individuals that are there. We have managed to have open the daycare centers for individuals with dementia, with some restrictions that half of them will be at the site at one time, but not all of them. And by that we have managed, I think, to solve this issue rather well. But there have been individuals that have been suffering, not least when they are so afraid of the virus that they are not coming to the daycare center.
Thank you very much.
Thank you very much.
Yeah, in Germany, of course, there's a discussion on when to open long-term care facilities or daycare centers in particular as well. At the moment, there's not yet a coordinated answer on this topic, but some state governments, some German states, some of our 16 states already issued plans on how to manage the end of some of the restrictions that were issued before. So, for example, visits to long-term care facilities are supposed to be realized in some states, but today, actually, there will be another meeting of all the state presidents and the chancellor, and maybe there will be news afterwards. But at the moment, there's no coordinated answer.
Thank you, Nils. I hope you can bring the message back to your government, and so hopefully everybody else. Nigel, did you have any question you wanted to raise? Just one. We got.
No, I didn't. I thought you were talking to me, but it was all broken up.
Okay, don't worry. We have had a lot of questions arriving online, but I think we are, as usual, running out of time. Can I ask D.Y. Suharya, please, the Regional Director for Southeast Asia, to try and attempt to get us onto an energizer, because we know this is a very big session. We have a big topic coming up. So D.Y., please lead us through your session. If all of the speakers could please mute so that your face will not appear in this session. Thank you.
Thank you, Paula. Hello, friends in Asia, Europe, Australia, Americas, Africa, and Middle East. Such an honor for me to share this brain gym exercise that I learned actually from my dear sister, who happens to be a risk reduction specialist in Alzheimer's Indonesia. In Asia, it's really popular to do dancing and music, you know, icebreaker and all that. We all know that based on literature, physical activity can actually increase the level of brain-derived neurotropic factor. And hopefully from this movement, you know, it will improve attention, memory, coordination, concentration, and it will uplift all of your mood. Just follow my movement, and the song is Fly Me to the Moon.
DY, thank you very much. You certainly have succeeded in waking me up. Way more alert now. Thank you. ADI, we practice what we preach. We need to keep our brain active and in the gym all the time. So now it is with great pleasure that I'm going to announce the second part of this webinar. But before I do that, I would like to remind you, now that you're all energized, that you must not raise your hand because we are not picking up raise the hands. If you have a question, please ask it in the Q&A in the chat box. If we cannot pick your question up now, we will pick it up eventually. And please, if you have a question that you see on the chat box that you would really like to have answered, can you please vote for it so that we will pick it up at the end of this discussion? And also, because many people are asking, yes, the slides will be available as well as a recording of this webinar. The previous webinar, the recording has been watched by well over 1,000 people. So we'll try and make this recording available as soon as possible. Now, can I please introduce you to theme 3, the impact of COVID-19 on the diagnosis of dementia. And I'd like to introduce Professor Ricardo Allegri of the FLENI Institute in Argentina. So Ricardo, it's a pleasure to have you with us. Thank you so much for being up so early. Would you please run us through your piece?
Thank you so much, Paola. Today, I will talk about the current situation of the elderly people with neurological disease in the presence of the pandemic in Argentina. Just a short introduction. As you can see, Argentina is the second largest country in South America, and our neurological institute, FLENI, is one of the most important in the region. Turning to the pandemic in Argentina, the first case was reported on March 3. On March 19, the government announced the quarantine with less than 100 confirmed cases and no death at that time. Mandatory social confinement was introduced nationwide and further restrictions were implemented for the elderly. These measures are still in place today. At the present, after 50 days in quarantine, we had 4,400 cases confirmed and only 250 dead people. Next slide, please. Yes. Since the lockdown was introduced, our Minister of Health suspended outpatient visits in all the healthcare system. And as you can see at the left of the slide, the number of emergency consultation and hospital admission at FLENI had dropped by 64% compared with the same period of 2019. Almost 50% less stroke, less seizure, less multiple sclerosis relapses. What's going on? Other problems have also with the elderly people with dementia. The stricter social isolation has been recommended. Therefore, family visit, assistance, and rehabilitation have been completely interrupted. As a result of this, negative psychological impact such as anxiety, irritability, and sleep disturbance. Also, the patient experienced deterioration of existing cognitive symptoms. Overall, we have seen an irrational mismanagement of patient and caregiver. Looking on the chart on the right side of the left, the impact of one pandemic of the health system had 4 main problems. First, in green, is the management needed for the morbid mortality of the pandemic. Second, in red, the attention required for the morbid mortality of the non-COVID case, acute disease such as hypertension, diabetes, stroke, seizure. Third, in blue, the lack of care of the chronic disease in the elderly people, such as a cognitive impairment or demented patient, that result in a greater deterioration of the patient. And beside this problem, when the pandemic blows over, we will have to face the post-traumatic stress disorder. Next slide, please. Finally, our action. For our patient and FLENI, we have launched an aggressive communication line. By telehealth, we provide several spots of recommendation. Telemedicine, we actively contact our patient by Zoom, Skype, or even by telephone. No, we decide to communicate with our patient. We developed a new battery for cognitive assessment through internet, and we have been organizing sessions of rehabilitation online. For the general population, we have published a series of recommendations for people with dementia related to prevention and how to live in time of pandemic. For public health, we have sent several warning calls to the government, to our colleagues, not to neglect the non-COVID disease, and most important, not to abandon the elderly people with cognitive impairment. Thank you very much. Thank you for your attention.
Thank you so much, Ricardo. Such an important message, I think echoed by a lot of discussion at the WHO this week around the importance of not forgetting other non-communicable diseases in the flow of interest and focus on COVID, because people are still having strokes, are still having heart attacks, are still developing dementia. We need to do something about that. Can I also remind everybody, please, that the preferred terminology that we suggest at ADI is for it to be people living with dementia when talking of people living with dementia. Thank you so much. Can I also ask now Professor Philip Scheltens, the director of the Alzheimer Center in the Netherlands and the chair of the National Dementia Plan, to join us. When I was speaking with Philip on a symposium 2 weeks ago, that's the first time I realized that there was an issue around the fact that people were not seeking diagnosis. And then I started thinking, what's going to happen in 6 months' time if people don't seek diagnosis now, therefore they will not be provided with post-diagnostic support? Will we end up with many people in 6 months' time having no clue about what is going to happen to their families? Philip, please join us.
Thank you, Paola, and thank you everybody also for giving their perspective. My talk will actually be very brief, and also because it's basically almost completely the same as the previous speaker. Next slide. The situation in the Netherlands is not different from any other country. As you can see on the left, we have an enormous amount of death every day, although the curve is going down, as you can see. I don't have the details of today, but it's going down more and more. On the right side, I just put on the number of deaths. In total, we have more than 4,000 people died already that were actually known as COVID sort of victims, but I think many more died actually, which they were unknown. But as you can see, the predominant gender is male, and it's also the risk category is between 75 and 85 in the 90s actually. Although we had the occasional cases of a lady of 107 actually who survived COVID infection and is actually still alive, doing very well. I think I will focus on the next slide on the impact that it had. I think it's the same as in the previous speaker. I think for patients already diagnosed at home, relying on daycare, it was a real sort of issue that starting with the lockdown early March, all the daycare facilities were closed. And you know that people are going to daycare also to release their caregiver from some of the burden. So they are now forced to stay in their house, sometimes very small houses, 24/7 on each other's lip, and that increases the caregiver burden enormously. Nursing homes are closed for visitors, so nobody can enter the nursing home actually. You have to see your mother or your father through the window, or have a sort of other sort of interventions are being tried to at least make contact, of course, with telemedicine, with iPads, etc., etc. And that's still ongoing as of today. This evening, the Prime Minister will announce probably some measures to be lifted and relieved, and maybe some nursing homes may actually open their doors for perhaps 1 or 2 family members. What is most worrying is that while the death in the community have gone down, the death rates in nursing homes have gone up, and the staff working there is extremely under pressure because there's also a lack of personal material to protect them from the virus. So that's a real issue that's being looked at the moment. For me, as working in the Alzheimer Center and all of the outpatient clinic in the Netherlands, we have closed all our outpatients visits as from early March, and we do almost everything we have done through telephone or other means of communication, as was said before. And actually, that of course we don't hardly see any new patients anymore. So new diagnoses have dropped completely. 90% less of diagnostic measurements were taken, but the people that we already are following, we're following by telephone. And actually that is some of the surprises I learned. It's actually so you can do this very, very well. And we got very positive feedback. All the patients that we call understand why they are not able to come, and they actually accept that they will be contacted with us. And it works really very well. So actually in the future, we will use this much more. From May 4th, just this week, actually, we are gradually upscaling. I'm in the hospital at the moment. I've seen 2 patients this morning, 2 new patients. So hopefully we will can continue this, because the non-COVID care for all the non-COVID related disorders have gone down tremendously. And we have to upscale this, because cancer diagnosis, all the emergency diagnoses have gone down tremendously. And these people, they are still there, but they don't come to the hospital. And I think there's a lot of hidden pathology over that you need to see in the future. But I think I'm optimistic in that sense that we can scale up and actually also perhaps try to retrieve everybody who's on the waiting list in a couple of months. Thank you.
Thank you very much, Philip. Now, we have received a lot of questions for this session. I just want to pick up a question quickly by someone called Jane Ward, who has just asked whether there are examples in various countries of how people are supporting people with dementia. Jane, there is another webinar that we did last week, plus there is a lot of examples on our website of how people are supporting people with dementia in all countries. So I invite you to have a look at that. Now, specifically on the content of Philip and Ricardo presentation, telemedicine is probably the thing on which we have received most questions. So what people would like to understand is, and Philip, you did hint to this right now, do you think this is now going to stay? Many people are saying also in other areas, for example, in universities, that the current situation has accelerated changes that were probably going to be implemented in 10 years in the space of 2 months. So do you think this is going to spell a great advance of telemedicine? And what do you think are going to be the advantages and disadvantages of this situation? So Ricardo first, please.
Okay, thanks, Paola. I think that is an advantage, and I think that is an evolution, but it's not the only communication with the patient. When the pandemic disappeared, I believe that the telemedicine will continue, but we will continue also with the presential visit. What happened with the advantage is in pandemics, the less risk of catching the virus, the possibility to see the patient who live very far from our hospital, more comfort for the patient. There are some disadvantages, it's true, difficulty for the elderly people in use internet. Most of our patients have cognitive impairment, and we need other people with the patient for the communication. Not all people have access to internet in South America, in Latin American country. It's a reality. Other problem, I'm unable to carry out the physical examination of the patient. Is difficult for the first contact with the patient, but I think that for the follow-up and for some rehabilitation and for contact with the patient and the family is a very good resource.
Ricardo, thank you. You've also addressed another one of the question we had received, which was about availability of telemedicine to people who live in areas where there is no access to the internet, for example, and that how that impairs it. Philip, would you like to add on that particular point?
No, well, I think under pressure, everything becomes fluid. So things that we have tried before were not possible, and they are now possible because of the crisis. So even our health insurance companies, they are now paying for the telemedicine, which they didn't do before. And that was one of the obstacles that for many hospitals not to do it, because you actually did it in your own time, basically. So that has all changed. So, and for me also, I think many of the return visits and even cognitive testing remotely can be done by telephone and also by video consult. We are also sort of having video consults, and the Netherlands is a privileged country because 85% of the people do have an internet connection, and even elderly people are very able to work with iPads and that sort of thing. So it's a pleasure actually to do, and it saves them to travel, it saves them trying to park the car here in the neighborhood. So I think many of those things will stay. New patients, the first time you have to see them physically, because you have to do the examination, you have to do the MRI, of course, and you have to do other things. But after that, I think we will turn to do more things remotely than we had ever done before.
Philip, thank you so much. That's all the time we have for questions. But Philip, thank you also for raising the important issue of insurers now accepting telemedicine, and that having been a step. Often we are finding throughout our webinars that all of a sudden red tape that actually was impeding some advances that were advantageous for people affected by dementia to be removed. And this may well be a very positive effect of what has been happening at that time. So thank you, Ricardo. Thank you, Philip. Please stay with us because we may pick up some more questions at the end. And now I'm going to bring you to the fourth and final theme of this webinar, which is the impact of COVID-19 on the biopharmaceutical industry. We have with us David Jeffries, who is going to run us through two completely different topics. One is the halting of clinical trials. We have been very concerned about that, especially as we knew that there was the possibility of a disease-modifying treatment this year. So this has been something that much of our constituencies has been very worried about. And finally, David is going to run us through the development of vaccination for COVID-19. So please do not raise your hand. Can I remind you, please, if you have a question throughout this presentation, put it in the chat box and we'll try and address it either now or in the final discussion, or we may contact you separately after the webinar. So David, please, the floor is yours.
Well, thank you very much indeed, Paola, and good afternoon and good morning to those, recognising we have people joining us, literally, I think, from across the globe. As you've heard, I'm David Jeffries. I am the chair of the Regulatory Science Committee of IFPMA, the Innovative Pharmaceutical Industry. But in my day job, or is it my night job these days, I'm Global Senior Vice President for ASI Pharmaceuticals, so very much aware of the issues facing those who are suffering with dementia. And also, as a local councillor, very much aware of some of the social and the care home issues which have been raised. I'm deliberately not going to share slides with you to make life a little bit easier today. What I just want to do is perhaps touch on 4 quick items to set the scene for us. The first thing I think I'd say for the innovative industry is that we've had to take quite extraordinary measures to ensure that we continue to manufacture and make available all those medicines which are essential across a wide range of conditions, cancer, clearly those treating people with dementia, but equally in many other areas. And that's been no easy task. We've seen disruptions in the supply chain, medicines, the active ingredients going from India, from China itself. We've also seen difficulties in getting various ingredients and reagents brought together into our factories. And of course, in addition, we've had problems in moving supplies out from the factories, and our own staff have been experiencing sickness. They're having to socially isolate on occasions. And in addition, we have to run a factory with people socially distancing. None of that is easy, but I'm pleased to say that we have been able to come through that. We've been able to maintain supplies. We've been able to ramp them up in various areas where medicines are needed for the treatment of COVID-19, and where we've seen unusual patterns of people indeed even stockpiling medicines. So that's gone well. The second area for our industry, as you've touched on, is obviously around the research piece. Those companies who specialize in vaccines, either vaccine manufacturers or those who are working with academia, with the universities. I've never seen things move at such pace. We've had great support there from the WHO and the regulatory agencies. Literally everybody has been in this together. You've seen some of the figures. I think we're well over 50 vaccines now being taken forward. We've seen vaccine trials which have already started, which is all very encouraging. That said, of course, we need a large number of vaccines, not least of which because these all work in subtly different ways to combat and to raise antibodies against the virus. We don't know which will work. We don't even know that any of them will necessarily work, things like dosage and so on. So that work is going at great pace. A lot of huge amount of resource being put into it with great support. But we need to recognize complex area of science, complex area of development, and then manufacturing an entirely new vaccine for effectively all age groups and across the world. That is a huge challenge, and it will take quite a while. I wouldn't want to put a figure on it, but we shouldn't underestimate the difficulties of getting the vaccine. In addition, the innovative industry has been looking across its portfolios, bringing forward many medicines, what we call repurposing, looking for medicines to be used in different ways, the agents against the virus itself, those to manage this cytokine storm, all those going ahead at great pace, and also adjuvants to make their vaccine work better. Finally, if we turn to the trials themselves, the first thing we've been very strongly committed to, particularly relevant in the Alzheimer trials, is keeping what I might call the integrity, keeping those trials, maintaining what we've got, maintaining those patients already recruited into trials. So if you think about it for a moment, what we don't want to see is all those results, some of them going back 2 years, being lost and wasted because we can't take the trials through to their final conclusion. So that has meant working closely with health authorities. It's meant ensuring that we continue to monitor the patients, we continue to get the medicines to them. Some of the trials involve giving the medicine into the body parenterally, and that means dosing patients now out of hospital. We've had to do just the same for cancer trials. This means a lot of extra effort, but a lot of innovative approaches. That's involving telemedicine, remote monitoring. That's all been done. And again, we've had great support from the regulators by what is known as regulatory easement. What that means is we haven't had to stop the trial when a key investigator has been called off to work as in intensive care, which some of them have done. When we've had to change the monitoring location, we've been able to continue those trials, and we've had a lot of flexibilities, let me use that word, from the regulators, which enabled us to do that. Those trials therefore haven't stopped, they've continued, and they will continue to give their results, which we hope will be positive, but that's a very encouraging sign. And then finally, of course, we need to make sure that we can take forward new trials. And again, we're very much committed as the industry that we don't lose ground. We actually take forward some positives out of this period so we can do trials even faster in the future and we can deliver. So that I think is a piece of hope I'd want to end on, that I think we are learning lessons, how to do trials better. I think some of these collaborations with the regulators will go forward. So let's be optimistic that out of this terrible tragedy, we'll see some good things for medicines for the future. And of course, across all this area, science is moving at a pace I think none of us have seen before. And that again can only be good as we tackle some of the major issues of which Alzheimer's disease has to be top of the list. So let me stop there, Paola, but hopefully that gives you an impression of what's been going on and continues to go on.
Thank you very much, David. This has been very interesting. I think you've touched on some issues that have been of concern to all of us. For example, the interruption of the production of prime compounds to make medicines, the closure of borders and the interruption of the supply chain, which we know has been a concern to many people, especially if they present other symptoms of other diseases as well as having dementia. We have been receiving quite a few questions prior to the start of the webinar, and I think you've started to address them. You've been talking about positives to emerge. I logged into a discussion with one of the biopharmaceutical CEO recently, in which he was pointing out how the regulators have been extremely helpful in trying to move the trials in a direction that will not drop them. I think a lot of people have expressed concern about exactly what you were mentioning before, that people may have, people are currently in trials may not be able to stay in those trials until they're brought to their conclusion. So David, perhaps you should go a little bit deeper into that point. Are you aware of any trials when there has been such disruption, and about positive measures? I know that everybody has been particularly focused on the trial for aducanumab, which has been something that we were hoping would finish within this year.
I think it's fair to say that I think all the trials have been able to be maintained through the period, and this has involved a lot of collaboration. I know for some of our trials, we've been using what we call the NHS volunteers to help to get medicines out to patients, because normally they get their trial medicines from a hospital centre. We don't want them going to the hospital. Many of them can't. They're socially isolating. So that system has worked well. Where we're having to dose patients at home, we've had the flexibility to do that. That has worked well. Also remote monitoring. So all those things which were seen as potential difficulties and roadblocks, we've been able to overcome with great support from a whole range of different people. In the past, when you made a change like that, with a technical term, it was known as a substantial amendment. You made those changes, you had to stop the rest of the trial whilst that was approved by the regulators. Now we're allowed to do it and tell, or do it and not even tell. That's been a really positive change. So we've seen that flexibility, all that has really helped. So I don't think we've lost any patients through any bureaucracy. Clearly people are, people are suffering from COVID-19. That's a separate issue. But I think we've been able to maintain those trials so they will come to a conclusion. Has the rate of entry into the trials slowed? Yes, as you've heard from Philip, it certainly has. Some of us have not actually stopped recruitment in this area. We've had to stop in the area of cancer for obvious reasons, because those patients might be seen to be so much more at risk being immunocompromised. So I don't think we've seen recruitment formally stop, but certainly bringing in new patients has been very, very challenging and difficult for all the reasons that Philip and others have outlined. Does that answer some of those points?
Yes, it does, David. Thank you very much. And I have been monitoring the chat line whilst you were speaking as well for further questions. There is another one that probably I should be answering rather than you, but thank you so much for those really positive points. I think it's been very strong what you're saying. No clinical trials has been halted. This is so important for our community. And as we picked up in our series on research participation last year, it's so important for the people living with dementia and their carers, which are undergoing those trials, for which it would be heartbreaking if those trials were to be withdrawn in some way. So it's great the industry is finding so many creative and interesting ways to go around that. The second question is really more for me. Somebody was asking whether charitable donations being dried will and being diminishing during this COVID-19 pandemic issue. That will mean there will be less money for research. Now, this is not necessarily a question for industry, because of course, David, pertains to the biopharmaceutical industry, which does not necessarily work on donations. But this is more for example, all those centers that work on dementia research, which are being funded by the public through their very generous donations. Well, I think it's fair to say that, yes, there has been a decrease in donations all over the world. We run also webinars which are private with our members, in which we have heard of many of our members having very serious difficulties even in maintaining their own operation, let alone in financing research. So it is no doubt that the landscape after COVID-19 will be different for dementia research and its funding. And once again, you know, if people are on the line and are in a position to make donations, please do make donations for dementia. They're still very much needed. And I think to an extent, the fact that, again, our constituency overlaps so strongly with the COVID constituency should give you pause for thought. We'll know a lot more now about how important it is to continue to fund your Alzheimer's Society, wherever you are in the world, and research into dementia studies. Now, I am going to bring this section to a close, and I'm going to introduce you to the next slide. And that is the free-flowing discussion with Dr. Serge Gauthier, who is the director of the Alzheimer's Disease Research Unit at McGill Center for Studies in Aging. But most importantly, Serge, for many years, has been the chair of the Alzheimer's Disease International Medical and Scientific Panel. Two of the speakers today, actually three, Professor Lee-Fay, Professor Ricardo, Allegri, Professor Philip Scheltens also belong to the panel, together with about another 100 professionals that provide the engine for our scientific and intellectual thinking around Alzheimer's disease. So Sergio, it's a pleasure to have you with us. I'm trying to see you on the screen. There we go. You are unmuted. So Serge, can I bring you towards telling us what have been your impressions of this panel? Do you want to pick any topic in particular?
Yes, I will do that. To help me, I have prepared this slide before hearing the speakers, and I'm happy to see that it's complementary. So the other thing is I want to reassure the audience that we are learning a lot from this experience, and things will get better in the treatment and research. That will be my take-home message. So just to pick up on the clinical care, telehealth or telemedicine, teleneurology now is a new term even used in the United States, will continue to be used after the initial face-to-face assessment. So Dr. Scheltens made that point already. And it's also true that insurance, whether private or governments, are now picking up the costs for that. One bit of news that came out under the radar 2 weeks ago, despite all the COVID attention in the media, there's still advances being published in the medical literature. And one of them is a blood test that was developed by researchers in Sweden. We were able to validate, it's also work that has been done by Dr. Scheltens in Europe, that there is a blood marker called p-tau, tau being the protein that builds up in your brain as you get older, and a specific fragment of it called 181 is measurable in the blood, and it reflects what's happening in the brain. So there'll be further validation on this, but this may be a low cost, just a blood draw test available worldwide later this year. The other good news is the clinical care now will have to increase caregiver education online. So we had pilot tested at McGill a dementia education program, which was using a simulation center, an apartment where we had a simulated person living with dementia and their daughter, and we could accommodate 20 to 25 people at a time. But now we're going to go virtual. So this is going to speed up something that we had planned to do in future years, education online for caregivers. And one thing we didn't talk about today yet is, perhaps Glenn mentioned that briefly, is we realize with COVID that people have to be clear about advance directives. If I get the pneumonia, I don't want to be on a respirator. I'm telling my family in verbally or in writing. So I think people will take seriously in the future their medical planning. What if I get a pneumonia? What if I have a stroke? I want this, I don't want that. And the big shift, I predict, also for care will be much more home care, like is done in many countries outside Western Europe and North America. More home care, less nursing home care for people in the later stages of dementia. And this will shift the costs of care. It will mean more education needed for caregivers. So that's clinical care from my perspective. I'll just briefly comment on the clinical research to complement what's been said. There is indeed a massive effort to do memory tests that we can do online, on phone, for those who don't have access to email or Zoom. And of course, if we have cameras, we can do a bit of neurologic exam looking at people, facial expression and mobility. There will be follow-up now for clinical trials. David mentioned the term remote monitoring. Indeed, it's going to be now acceptable to do clinical trials with in between visits at the hospital done by phone or online. The medications are indeed being shipped home in the current trials, and maybe we'll have less need of people going to the hospital just to pick up medications when they are in a clinical trial. And we did consider doing physical stimulation modules and cognitive stimulation modules online. I see that in Argentina, you already are doing it. Good for you, because there are non-pharmacologic clinical trials involving physical and cognition training that now we can shift from in-person going to the hospital to online training. And one last important topic, which was not covered today, is the increased deaths in the later stages of dementia. In some countries or parts of countries, it may involve up to 1/3 of persons who are living with dementia in the later stage may die within the next month or two. And this may change prevalence figures. What we don't know is dementia a specific factor in addition to having the COVID infection? And this will need clarification from epidemiologists. And finally, as I mentioned, the fact that we had so many deaths in long-term care, institutional care, will probably lead to the current newly diagnosed people to plan for home care all the way through the illness. So that's my complimentary overview of the topics, and I'll look forward to your questions.
Thank you so much, Serge. I think this has been a fantastic wrap-up of all that we have discussed. I think there is so much to think about more home care, less nursing home, telemedicines, as we have talked about before. But can I please ask one of the people that I know is online, and that is Dr. Catherine Seher of the World Health Organization, to please unmute herself and let us know if she has any particular comment on one of the points that Serge has asked, that in view of the fact that there may be an increased amount of deaths of people living with dementia during this COVID crisis, there may be an alteration, a shifting in the global figures of prevalence and incidence, with at the moment, Alzheimer's disease international is putting to about 50 million people. And those figures were about to be reviewed this month, indeed, the World Health Assembly, which is now going to focus, rightly so, on COVID. So Catherine, if you're on the line, would you like to, in very little space of time, give us your points?
I'll try my best, Paola. I hope you can all hear me. Thank you very much for giving the floor to me. Yeah, and greetings from the World Health Organization. As you can imagine, we're very busy these days. And as we all heard, it's unprecedented times and challenges for all of us, for countries all over the world. We're all in this together. Serge posed a very interesting question to which we don't have the answer yet. He was right in saying epidemiologists will have to look into this. A related question that we at WHO have and are concerned about, that has to do with dementia prevalence and would kind of counteract the hypothesis that Serge was proposing, is that the extended lockdown and some of the COVID pandemic measures that countries are putting in place actually are putting the older population at risk for cognitive decline and dementia. So we have our risk reduction guidelines, and we know exactly that lack of physical activity, social isolation, and lack of cognitive stimulation or social contacts are bad for people's brain health. And so we're worried, for example, that extended periods of time might cause a greater number of people developing dementia or cognitive decline. And we're working on ways to counteract and with public health measures protect our older populations in these difficult times. But that's also just an assumption at the moment. We're making all educated guesses, and like the issue with epidemiologists, this is something that we would need to look into and monitor very closely with the countries, with civil society partners on the ground, to make sure that we're coming out of this stronger, that we're taking the advantages with us, and we're trying to mitigate the risk and the negative effects as much as possible. And I think I'll leave it at that for now, but thank you very much.
Catherine, thank you so much for coming in, following the webinar at this time when we know that all of your colleagues in the WHO are so busy. Serge, given you're on the panel with me, would you like to comment on any of the points of Catherine specifically?
So I'm very glad WHO will do, like us, an assessment of what we've learned and how it will improve our prevention strategies, including where people live. The other thing that's positive, since we have a very international audience, is different countries have had different levels of mortality, and hopefully when we measure cognition after COVID, maybe there'll be less of a cognitive and functional decline in some countries or parts of countries, and that may help us for fine-tuning our prevention strategies. Another way to say that is some people have done better than others for mortality, and I predict some people will do better than others for just general well-being. Like Argentina had a video on TV with cognitive and physical training. Will Argentina do better when we measure cognition and function after COVID, the next follow-up for people we know living with dementia? So another way to learn from the COVID pandemic is to compare different countries and different parts of countries.
Thank you very much, Serge. Very good observations. We've had so many questions. As ever, we will attempt to reply to some of your questions directly afterwards. You'll be able to see these webinar slides again. There's been a question about intervention from Asia and African countries, Middle East. Please refer to our previous webinars. This is a series. There were plenty of participants from those countries in the previous webinar that gave testimonies. We cannot have all of the panelists all the time. That panel had 15 speakers, so please do watch our previous webinar of 2 weeks ago. There's been a very important question that has been asked by many people, and that has been how to liaise with relatives that are not being able at this moment in time to go and visit their loved one in care homes. That question was also raised in our previous webinar. We will attempt to give you some tips and some advice taken from the different countries, because as somebody pointed out earlier, this situation is different country by country, so sometimes one has to be aware of the cultural differences, and this is what ADI aims to do, to look at specific issues culture by culture. So we will try and do that in the weeks to come. Now, I'm going to bring you to the next slide, which is our poll. We want to ask you all what should be the next topic that we will embrace in one of our webinars. So could you please kindly let us know after hearing this webinar. This is going to take some time reading these questions. And please bear in mind there is quite a lot of questions at the bottom of this chart. So please scroll down to make sure that you read all of them. What would you like us to speak more in the next public webinar? These public webinars are proving to be extremely interesting for many, many of you, and we aim to provide you with topics that are of interest to the vast majority. So we're going to allow you a little bit more time to vote, as we would like all of you to have a chance to take the poll and give us your opinion. We know there is a lot of questions and some of these may be difficult to read. We've tried and make it easy by putting the topic of the possible webinar at the front. So we have advanced care planning, long-term care, epidemiology, seminars that would be topic specific, something about the hidden groups, the groups which are less well represented. I think everybody has had the chance. I can see the poll is now growing very slowly. And I think the quality of life of the elderly during COVID, who gets to decide what a life is worth, is the one that has received most vote, followed by long-term care. So we will endeavor to do a webinar around those topics. Given the interest you have, can I please point all of our viewers today to the 2 position papers that we have published on our website very recently. The link to those will be sent to you by the team after the webinar closes. You should really read those because they deal with both of those topics in great detail. Can I also remind those of you that are still on the line that we are a charity, so whilst all that we do is free to everybody, we would appreciate if you could make a donation if you can afford to do so. And finally, can I thank my fellow panelists for having given their availability in a very short period of time, for having given us such a fantastic summarized views. We hope that the webinar has been engaging, and as ever, thanking the incredible members of my team, to start with DY Suharya, who you all seen performing a brain gym. We've had a lot of great feedback for that. But let's not forget that there is a lot of people in the background of these webinars. And in particular, I would like to thank Laura De Bass, Wendy Widener, and Annie Bliss for being on the line with me, together with Katie Bingham, throughout this complex and intense webinar. I hope you enjoy it. And if you're watching this in recording, remember you cannot vote for the live polls, but we hope to see you live with us again at a future webinar. Thank you very much.